Hello and welcome to Season 2, Episode 92 of the Physician Assistant Exam Review Podcast. This week, we're going to be starting the genitourinary system. I'm Brian Wallace, founder and creator here at Physician Assistant Exam Review, where we teach PA students how to dominate PA school and ultimately pass the PANCE and land their dream job. That's really the goal, right? If you find this show helpful, if you like the way I teach things, there is something you can do for me. You can share the show with your friends and classmates. That would really help me out. It would really help them out and be a win for you, for me, and for them. So if you go ahead and do that, I would really, really appreciate it. Please, I don't advertise on the show. I don't advertise for the show. The way that this show has survived so long is through word of mouth, through you recommending the show to other people, from professors recommending it to students, from preceptors recommending it to students, from upperclassmen recommending it to lowerclassmen, and horizontally from people in one class recommending it to each other. That's how the show grows. That's how the show is maintained. So I'd really appreciate it if you would do me a favor and your classmates a favor and continue that trend. Now, if you'd like to get more of what I do, head over to the website, www.physicianassistantexamreview.com, and you'll find all of the show notes from today's shows and all the previous shows. You'll find all of the past episodes, and you'll learn how to get on the email list, which is ultimately the most important thing aside from the podcast. That's where you can get access to every back issue or episode of the podcast. You can get daily tips, tricks, and techniques for how to dominate PA school. All of that comes through the email list. So head on over to the website and go ahead and get your hands on that. I think it's going to be extremely valuable for you. Now, we're going to be starting with the genitourinary system. And as always, we're going to start with our priming question. So let's do that right now. As always, I don't expect you to know the answer to these. That's not the point. The point is to get your brain working, get your brain warmed up. Just like a muscle, we need to get blood flowing into the different parts of your brain. And we don't want you staring off into space as you run, as you drive. We want you paying attention and thinking, and not just letting this information wash over you, but for you to be an active participant. So the first one is something that I think each and every one of you, no matter what your stage in your career, can probably get your head around, which is what type of kidney stone is the most common? What type of kidney stone is the most common? I almost gave it away. Describe overflow incontinence. This is going to be a little tougher. Describe overflow incontinence. And our third one for today, what is the medical term for bladder prolapse? What is the medical term for bladder prolapse? So just up front, I want you to know that I do not love the way that the NCCPA blueprint has set up the genitourinary system. I think there's just a lot of overlap and places where things are categorized. Maybe they did the best job that they could, but there just is a lot of overlap in things that move into different sections. So I think there's different ways you could have set up the outline. So I'm trying not to fight that, but I'm just going to let you know up front that it is driving me nuts. So when we say, one thing I want you to notice, and when I talk about overlap, a lot of it is with the reproductive system. And they separated these two out in genitourinary and reproductive in the blueprint, which I get, totally makes sense. Except when we say reproductive system, we're pretty much talking about the female reproductive system. We're talking about the female breast, we're talking about pregnancy, we're talking about the cervix, menstruation, ovaries, uterine issues, and vaginal problems. When we say genitourinary system, we're pretty much talking about the urinary system and the male genitalia. We cover the bladder, the ureters, the testes, and the penis. Now, it says very clearly in the heading on the blueprint, reproductive system, male and female. Genitourinary system, male and female. And it kind of is. But it kind of isn't. And they sort of overlap, and then they pull out the male more into genitourinary and the female more into reproductive, which I do think makes sense. I'm not against that move at all. I do think that makes a ton of sense. I just want you to be aware when you go through it and the big heading says male and female, it kind of means that, but kind of doesn't. So, in this section, we're going to cover the urinary system minus the kidney. The NCCPA blueprint puts the kidney under renal. So again, there's tons of overlap here, right? We could pull renal in here. We could pull reproduction in here, but we don't. And I think that, again, like I said, that makes sense. We're going to cover the urinary system except for the kidney, which is going to be the ureter, the bladder, and the urethra. And we're going to cover the male reproductive system, so the penis, the prostate, and the testicles. Today, We're going to stick strictly with the urinary system. And in fact, we're going to do a little with the urethra, but not quite. And we'll pick that up when we get to the penis and we talk about some of the issues there. So for starters, they do include nephrolithiasis here, kidney stones under the urinary system, which is fine. They are obviously created in the kidney. They can stay in the kidney or they can move down the ureter into the bladder and out through the urethra. 85% of kidney stones are made of calcium, right? 85% are made of calcium. So that's a big one. Why do I say that's a big one? Because it's easy to ask a test question on. It takes no work to write that test question. 10% of kidney stones are made of uric acid. And then obviously that brings us only up to 95. So there's a bunch that are falling to that other 5%. For our purposes, we are not going to get down into the weeds that far. Like I just said, the stones may stay in the kidney or travel down the ureter into the bladder. Stones may become lodged in the ureter, and that's where we get pain and obstruction. When those stones actually block the passage of urine through the ureter, we get significant pain, and we get a blockage of the flow of urine. So we get that outflow obstruction from the kidney, which can back urine up into the kidney. We can get a hydroureter or a hydronephrosis from that fluid backing up, right? That should make sense. That should be pretty straightforward. Our clinical presentation. So again, I think it makes a ton of sense to think about how these patients will present into the OR, because that's how I see them, how patients will present into the clinic, how they'll present into your office. And the reason that's helpful is twofold. One, it's how you're going to treat patients in the world outside once you graduate. Hopefully you when you get that far, right? You're going to graduate and you're going to see patients in the office, and they're going to come in and they're going to have complaints. So it makes sense to learn what those complaints look like. Then again, that's also going to be how the test questions are phrased. A patient comes in presenting with XYZ. So it makes sense to learn from this perspective. The clinical presentation for a kidney stone, hopefully you know by now, but if you don't, severe flank pain. These people are in an absolute ton of pain. They are writhing and turning and getting up and walking around and really hurting. Also known as renal colic. The intensity can vary, but it's usually cyclical. It comes on and then goes away. It comes on and then goes away. And it can absolutely be excruciating. I know a few people, I don't treat these, so I don't see them in the office, but I do have a couple of friends and family members who have had this. Maybe you have as well. And their description is not subtle, right? It's not like, oh, it hurt a little. It is excruciatingly painful once that stone gets lodged. Now, it may not be, but it can be. These patients can also develop a fever and blood in the urine, secondary to that stone cutting up the ureter a little bit. Lab studies and physical exam findings. So these patients will come in, they may be diaphoretic because they're in so much pain. These patients are unable to sit still, so they'll be up, moving around, twisting, writhing, turning, all of these things, which should be a little bit of an indication for you if they're in that kind of position. During GI, we talked about peritoneal signs, right, with rebound, tenderness, guarding, and so on. Those patients don't want to move. They're terrified to move because it hurts. So you have a patient with appendicitis or a torsed ovary, they don't want to move, right? Any motion is painful. Any bounce of the stretcher is painful. So if you have a patient coming into the office who's holding their side and talking about excruciating pain, but they're up and walking and moving, well, you know you don't have appendicitis, right? So you have to start thinking about how you're going to address these things and how you're going to separate out these diagnoses. So that's one way, is just to picture that person moving around, holding their side, and just crying in pain. One place to start is with a urinalysis. You may see blood in the urine, as we said, on a microscopic level. You may see evidence of bacteria. Imaging is really going to be how you diagnose this. I mean, you're going to get a lot from the history and from the physical. As I said, a CAT scan seems to be the standard because you're going to be able to see very, very clearly what's going on. An ultrasound will probably work, and an abdominal x-ray will also likely be effective. If possible, you can identify the stone. If it can be, you have the patient urinate through a strainer, like a little screen, and it can catch the stone, and then it can be sent off so you can figure out more about it. You know, You may not be able to do this, but if you can, it's nice because sometimes people have recurrent issues. So if you can determine what's causing what type of stone it is and then what's causing it, that can be really helpful. Treatment. Okay, so how are we going to treat these? First of all, we're going to do prevention. And when we talk about prevention, we're talking about people who have recurrent stones. We're not really preventing, a healthy 20-year-old isn't going to necessarily be on kidney stone prevention, right? It's not really a thing, except for the idea that the mainstay of prevention is to increase fluids. You want to get about 100 ounces per day and understand that 128 ounces is a gallon per day. So it's a good amount of water. Certainly not too much to get through in a day, but most people in the United States would have to concentrate to get through 100 ounces of water per day. These patients could also get a thiazide diuretic, which will lower urinary calcium excretion. Now, once a patient has a kidney stone and they have presented, one of the mainstays of treatment is going to be pain control. So you're going to give them morphine or something else to help with pain. For years and years and years, patients were given increased fluids to help speed up the passage of the stone. Recent studies, maybe even not that recent, have shown this to not be all that effective. IV fluids is plenty, standard IV fluids. Alpha blockers, though, have been shown to be helpful. These dilate veins, arteries, and the ureters. So this can be helpful to dislodge even large stones and help them to pass through the ureters because you get that widened tube, right? And then the stone doesn't get stuck. And then obviously, if this is either a real problem where you have hydronephrosis going on, you have extreme pain, those kind of things, or it's been going on for a little while because you can get a bacterial infection secondary to all this, the lack of flow of urine and getting that stone stuck in there, you're going to want to remove the stone surgically. So either shockwave lithotripsy or endoscopy, you can actually go up into the ureter and get the stone. All right, now we're going to move into the bladder, disorders of the bladder. So then we basically have two that we're going to talk about today. One is bladder prolapse, and the other is going to be incontinence, which is largely a bladder issue, except not all the time. Sometimes it's a urethral issue. Let's go through the different types of incontinence. Actually, before we do, let's back up 1 second. What is the most common type of kidney stone? What's it most commonly made of? 85% are made of calcium. Think through for a second. What is the presenting patient look like who's presenting with a kidney stone, with a painful kidney stone? What do they look like? Well, they're up walking around, complaining of excruciating pain. They may be diaphoretic. They may have a fever. And then what was the medication class that I recommended for helping to get stones to pass? What was the medication class? Do you remember? I just said it. Alpha blockers. They'll help dilate the ureters. All right, incontinence, types of incontinence. As we move into the bladder, you can have stress incontinence, urge incontinence, overflow incontinence, and functional incontinence. You can also have mixed, which means a mix of these where you don't just have one issue. As you get into older patients, you start to find that people have less and less one particular problem you can solve and more a group of problems or a solar system of problems that will overlap and cause other issues. Incontinence tends to be like that, where we get a multitude of problems going together to cause overall incontinence, but it can be each type. So stress incontinence. This is pretty common in women after having children and as they approach or go through menopause. This is a leaking of urine secondary to an increase in intra-abdominal pressure, like coughing, jumping, or laughing, etc. This is more often due to urethral incompetence. So what this means is someone who's had a couple of kids and their estrogen level has gone down can have some issues with the way the urethra moves to stop urine from passing through it. So if you increase intra-abdominal pressure by jumping, laughing, coughing, etc., that urethra will no longer stop the urine from coming out, and you get some stress incontinence. So you get some leaking of the bladder. when those conditions apply. Urge incontinence is a little bit different. This is a sudden feeling of uncontrollable urgency, and is associated with the loss of urine. This is often associated with overactive detrusor muscles, so they're squeezing when they shouldn't be. It can also be associated with some neurological issues. And sometimes we also call this overactive bladder, which the blueprint has pulled out as its own topic, but I'm going to just incorporate it here with incontinence because it really just, to me, seems like it falls into the right place here. You can have overflow incontinence, which is this one took me a little bit to understand. It's an it's an involuntary voiding without an urge to urinate, right? So you have urge incontinence where the person suddenly feels they absolutely have an urge to go and they can't control it and they just urinate. But with overflow incontinence, we have the opposite. We do not have an urge to urinate, but we lose a lot of fluids. And the reason behind this is it's usually secondary to urinary retention. So what happens is the patient doesn't fully void when they go. So they're left with 200, 300, 400, 500 mLs of fluid in the bladder after urination. And at some point that lets loose. This is often due to an outlet obstruction, think BPH, or an underactive detrusor muscle. So we're not squeezing out, we're not pushing that urine out. So we're left with urinary retention, which is really the cause for an overflow incontinence. And the easiest one to wrap your head around is a functional incontinence. This is a leakage of urine due to cognitive or physical barriers. So think about, you have a surgical patient who you just did bilateral total knees on. They can't get out of bed and go to the bathroom. At some point, they lose control of their bladder and they urinate in the bed, and they don't have a stress incontinence, they don't have an urgent incontinence, they don't have an overflow incontinence. They simply can't get to the bathroom. They have a functional incontinence. They have a physical barrier to getting to the bathroom. If you have a demented patient who's unaware, that could be a cognitive barrier to getting to the bathroom. So that's functional incontinence. Clinical presentation. I grouped these all together because how they will present will be similar. It's not the same, but it will be similar. And the same thing with the treatments and the physical exam findings and so on. You're going to have to think a little bit to separate these out in the office and on the exam, but they're kind of very similar. So we're going to go through them as one thing and then separate them out as we go for you. So clinical presentation is involuntary release of urine, right? That's incontinence. That's urinary incontinence. These patients may also have frequency, urgency, and nocturia is another good one. So getting up to urinate overnight more frequently than they normally would. Lab studies and physical exam findings. Again, their major thing here is a good history. Most patients won't bring this up and are hesitant to discuss it, so you're going to have to bring it up. A good history is also going to include if they feel like they need to go every hour or every 2 hours, or if they have issues with leakage, or if they have issues getting up overnight, or in fact, wetting the bed. You're going to want to look for a urinary analysis. Basically, you're looking for signs of infection because that can certainly cause a problem. That can mimic these other types of incontinence. You can do an ultrasound for a post-void residual volume. So again, like we said, for overflow incontinence, you can diagnose that by looking at, after a patient voids, how much fluid is in the bladder. You can do a urinary stress test, which is when the patient's bladder is full, you have them cough. And sometimes you can do a cystoscopy, which is actually to put a scope inside the bladder so you can get a better view of what's actually going on. Treatments, again, these are going to be somewhat specific, but somewhat general. So schedule fluid intake, meaning don't ingest a lot of fluid 2 to 3 hours before bed, might be a recommendation. Maintain a healthy weight. If we have increased intra-abdominal pressure, we can increase problems with the bladder, right? Scheduled bladder emptying every 2 to 3 hours. If you need to go or not, you go to the bathroom. Reduce caffeine and alcohol intake. These are some very straightforward behavioral adjustments these patients can make to improve their situation. Discontinue any medications which may cause incontinence, especially anticholinergics. In particular, as women get older and go through menopause, estrogens can help, and also Kegel maneuvers to increase pelvic floor muscles. These patients may need to straight cath themselves in order to get the bladder completely empty. You can use suprapubic pressure during voiding to help empty the bladder. Some medications may be helpful, so topical estrogens may be helpful for urethral incontinence. Alpha blockers may be helpful for BPH. And anticholinergics may be helpful for relaxing the detrusor muscles in the bladder. So that's where you get that urge incontinence, or which would help with urge incontinence. If it's so you can get an overactive detrusor muscle or an underactive detrusor muscle, right? One would be urge incontinence and one would be overflow incontinence, or at least lead to it. They may be multifactorial causes for these issues. And then you can do surgical corrections. So you can put in a urethral urethral sling, which is a small piece of mesh that pushes up against the urethra to give the urethra something to push against as it contracts, and that will help with stress incontinence. You can do a sacral nerve stimulator for urge incontinence, so that interrupts and changes the nerve signals to the bladder, which can help with that overactive bladder. All right, so we had 4 kinds of incontinence that we talked about. What were the 4 kinds of incontinence that we talked about? Think about them in your head. There are four types of bladder incontinence we talked about just now. So you had stress incontinence, urge incontinence, overflow incontinence, and functional incontinence. To me, stress incontinence and functional incontinence are relatively easy to get your head around. We increase intra-abdominal pressure through activity, and because the urethra is in a weakened state secondary to pregnancy and aging, it doesn't do such a good job of closing off the bladder, and a little bit of fluid leaks out, or a lot of fluid leaks out. Functional incontinence, the person cannot get to the bathroom for one reason or another. It's urge and overflow they need to separate as far as test questions go. And urge is when you get that uncontrollable urge to urinate, and overflow is when you don't have an urge to urinate, but you lose control of your bladder either way. All right, not bad. Let's move on to bladder prolapse. What's the medical term for bladder prolapse? It's a cystocele. So this is the bladder herniating into the vagina. So the anterior wall of the vagina gets a bulge in it where the bladder is now coming down. Clinical presentation, this is a feeling of pelvic pressure, protrusion or bulge in the vagina, the anterior wall. You can have dyspareunia and difficulty emptying the bladder, which makes sense, right? This can lead to overflow incontinence, right? Because if the bladder is hanging down past where it should be, the muscles actually have to push the fluid up and around rather than just straight out. So you can lead to a situation where you're not fully emptying the bladder if you have a cystocele, if you have that bladder prolapse. Treatment. First of all, you can have non-surgical treatment, right? So a vaginal pessary will physically push that up, right? So it's a ring you put into the vagina, and that will push the bladder back into place. This is not a great long-term solution because it can cause issues in the vagina and some scarring, but it's an okay solution. Kegels, so we're going to strengthen the pelvic floor, and that may help. And then eventually you wind up in a surgical setting. So you can have an anterior colporrhaphy, which is a surgical procedure where you take some, they don't even use mesh anymore, where you're putting in some material to help hold up the bladder. Let's just call it that for now. It's a much more complicated discussion than we want to get into here. But it's a vaginal surgery where we're going to use some material to hold up the bladder. Now, a more definitive procedure would be a hysterectomy with a sacrocolpopexy, which is, this is a procedure I actually perform on a regular basis. I work with a urogynecologist, and what this procedure is we go in robotically, we do a hysterectomy, then we dissect the bladder off of the vagina from inside the abdomen. We dissect the rectum off of the posterior vagina. We dissect down to the sacral prominence. Then we use a Y mesh and sew it to the anterior portion of the vagina, the posterior portion of the vagina, and then pull it up, and the Y arm gets attached to the sacral prominence, essentially pulling everything back up and replacing the uterosacral ligaments that are no longer functioning in these patients. And this is why this is a little bit more extensive procedure, obviously, than just for a cystocele, but it helps to fix the cystocele and uterine prolapse. So anyway, that is, I don't want to spend too long there. It is something I do frequently, so I sort of can't help but talk about it a little bit, but it's not something that you really need to know. But it is the definitive treatment for this issue. Another one is you could do a uterosacral ligament suspension, which is to oversew the uterosacral ligaments, which will help pull up a uterine prolapse and help to fix the cystocele as well a little bit. So anyway, those are your surgical corrections for a bladder prolapse. That's as far as I want to get today. We'll get more into actually, one more quick thing. They have separated out urethral prolapse, which is, you can call a urethrocoele. And this can be surgically corrected, but it's where the tip of the urethra actually prolapses out a little bit from the rest of the body. But I think we're good there. That's about as far as I want to get for today in our introduction to the genitourinary system. Now, before we wrap up and get to to answer our priming questions, I do want to click on or hit on one quick study tip for today. And this is something I just got from a book I'm rereading, which is called Essentialism by Greg McKeown. A really good book. And if you have some time, I do recommend that you look it over. But I want you to listen to this for just a second. And this is on timing of the work we're going to do. So the term for underestimating how long, this is straight from the book, by the way. The term is for a very common phenomenon known as the planning fallacy. This term, coined by Daniel Kahneman in 1979, refers to a people's tendency to underestimate how long a task will take even when they have actually done the task before. In one study, 37 students were asked how long they thought it would take to complete their senior thesis. When the students were asked to estimate how long it would take if everything went as well as possible, their average estimate was 27.4 days. When they were asked how long it would take if everything went as poorly as possible, their average estimate was 48.6 days. In the end, the average time it actually took the students was 55.5 days. Only 30% of the students completed the task in the time they had estimated. So, if you didn't catch that, here's the point. We as humans stink at estimating how long things are going to take, even if we've done them before. We're not good at it. So in this particular study, what they did was they took a bunch of seniors and asked them how long they thought it would take them to complete their senior thesis. If everything went perfectly well, when they thought about it, they said it would take us about, on average, 27.4 days. And if everything went terribly wrong, they thought on average it would take 48.6 days. And the reality was it took an average of 55.5 days, which is way longer than they thought. I see this all the time in the operating room. Surgeons come in and think that they can complete a surgery in a given amount of time. And I know it's not possible, but it happens over and over and over and over. Another phenomenon that actually McKeown talks about in his book here, Essentialism, but I've also noticed on my own and picked up in a lot of places, is the idea that if we can do something one time at the fastest possible time, we think that that's now our new average. So a surgeon does a hysterectomy in an hour and a half. Now suddenly they think every single hysterectomy is going to take an hour and a half, when they normally take about 2 to 3 hours to do it. It's the same thing for you when you study. We're not good at estimating our times. In fact, we're terrible at it. So my study tip for today is to try to give yourself some buffer time. And this is what kills people. They don't include any buffer time from one task into the next. You make a schedule from what you think you can get done from 1 to 2, then from 2 to 3, then from 3 to 4, with no time in between to get a drink or go to the bathroom. Or, God forbid, you miscalculate how long it's going to take you to do something and you run over. So my strong recommendation is to add 20 to 50% to your time estimates. If you think something will take an hour, assume it's going to take an hour and 15 minutes to an hour and 20 minutes, to maybe even an hour and a half. This will make you so much less frustrated over time. And you're still going to get the same amount of work done. It's not going to matter. Unless, of course, you can stick to that timeline and just enforce it brutally and say, I'm going to study for 1 hour. And at that 60-minute mark, boom, you are done. That's another struggle and a whole nother discussion. So I don't want to go down that path either. But in most cases, we stink at estimating how long a task is going to take us, even if we've done it before. And keep that in mind as you plan out your days and your weekends and how things are going to get done. Even once you're a practitioner, how long it takes you to see patients, how long it takes you to do your charting. We are notoriously bad at estimating that stuff. So stop trying to fight it and start trying to work with it. All right, let's go ahead and wrap up with our priming questions for today. We've said this a couple of times. What type of kidney stone is the most common? Calcium is 85%. Uric acid is 10%. Describe overflow incontinence. Overflow incontinence. That was when we do not get an urge to void and we spill urine, secondary to urinary retention. Think BPH or underactive detrusor muscle, something that's causing us to not empty when we void. What is the medical term for bladder prolapse? What's the medical term for bladder prolapse? Cystocele. All right, great. So this was an excellent beginning to our journey through the genitourinary system. We will pick up next week with the urethra and the penis, and we'll cover some very interesting topics there. Until then, good luck on your exams. Good luck on your tests. Please keep me posted on how you're doing and head over to the website, www.physicianassistantexamreview.com to get on the email list and get those daily tips, tricks, and techniques for getting through PA school. And please, like I asked in the beginning of the show, please share the show if you got something out of it. If it's helpful, if you like the way I teach, please help me out and share the show. Thank you and good luck.